Hello, this is Graham Brown, Principal with the NextGen Advisors. Welcome to our podcast. Today I'm joined by my colleagues, Dr. Betty Rabinowitz and Dr. Marty Lustig. Good morning and welcome, Betty and Marty.
Good morning.
Hi, Graham.
Today we want to explore the topic of patient adherence with a care plan. There is some literature to estimate the cost of medication non-adherence, but little on the overall impact of other forms of non-adherence. An often cited statistic from a review in the Annals of Internal Medicine purports that 20 to 30% of prescribed medications are never filled at a pharmacy, and 50% of medications for chronic conditions are not taken as prescribed. This lack of adherence, the Annals authors wrote, is estimated to cause approximately 125,000 deaths and at least 10% of hospitalizations. The associated cost to the American health system is estimated to be between $100 billion and $289 billion a year. The global pandemic challenged patients and providers alike to maintain regular communication and keep on top of a plan of care. For the purpose of today's discussion, we're using the term adherence, which the World Health Organization defines as the extent to which a person's behavior corresponds with agreed recommendations from a healthcare professional. Adherence is broadly related to instructions concerning medicine intake, use of a medical device, diet, exercise, lifestyle changes, rest, and return to scheduled appointments. So let's set the stage a little bit and explore some examples. The research suggests patient compliance and adherence depends on a number of factors. Betty, start us out with this. What are some of those key factors?
It's an interesting question. One of the main issues that patients confront is the complexity of the treatment schedules we provide them. There are medication doses, different regimens with multiple medications, different cadence and intervals during the day that become very complicated. Those of us who are fortunate to be healthy can report how difficult it is to take a single medication for a week for an infection or a simple issue. And we send elderly patients home with 15 medication at different intervals, different times, which just is extremely daunting. Clearly, foundationally, the context in which these recommendations are made is important. So if there is a relationship of trust between the patient and the physician, it will be easier. It's been shown that patients are more likely to pick up the medication and actually take them. If mistrust or unfamiliarity is there, the patient doesn't know the physician, that's less likely to happen. Certain conditions have regimens that are easier to adhere to or less. So, for example, patients with dementia struggle specifically with adhering to medications. And then there are obviously a slew of socioeconomic and biopsychosocial elements like affordability, complexity of even attaining the medication, elderly homebound patients who don't have pharmacies that deliver the medication. We kind of bundle those in environmental factors that make adhering to a complex regimen extremely difficult.
I was interested to learn in preparing for this that there's also some research that indicates that individuals that are of an older age, have a higher level of education, have higher socioeconomic status, or are retired or married, are associated with better compliance with the treatment. And another study from Crott and Souza in 2017 looked at what factors impact patient adherence with medical advice. And they note that other positive factors include accessible and comprehensible form of communicating the medical information, so a real understanding for the patient of what their needs are and how to adhere with the program, continuity of care, the patient's satisfaction with their experience of care, and then shorter intervals between appointments and shorter waiting times. So really a better experience and more continuity in engaging with their provider. So Marty, let's talk a little bit more about the doctor-patient relationship. Trust would seem to be pretty paramount here, but that isn't always easy to establish. What in your experience has been important and influencing that trust in a doctor-patient relationship?
To me, there are kind of two foundational concepts that underlie building trust with patients, and that's caring and competence. I was fortunate when I first started in practice to have a surgeon who was a Vietnam veteran who sat me down, and the first thing he said was, patients don't care what you know till they know that you care. And coming from a surgeon, that was a really powerful statement to me. And it's not that competence isn't critically important, but really patients knowing that you respect and care about them. And what stems from that is, being a good listener and meeting them where they are, not where you want them to be, and being responsive to their questions. I think what flows from being caring and competent will build trust. And the other important component of this is time. We hope in primary care, as a pediatrician, we typically do have the opportunity to build trust over relatively minor issues over time, so that when and if the more critical issues occur that can have greater consequences for patients, that there's already a trusting relationship there that really helps you work through those most difficult decisions that you need to make with your patients.
Mm-hmm. I'd be interested to learn from each of you in your own experience as practicing providers. What are the impacts when you have a patient that may be actually quite complex or quite ill and they're not adhering to a plan? How have you seen those type of situations unfold? Betty?
I think it's much more common than we have even commented about here. From time to time, I would ask patients to come in with a shopping bag to collect every single medication that they have in the home. And patients would come in with plastic bags full of unopened pill bottles that were prescribed way long ago that still had the full complement of medications in them, where obviously they weren't taking the medications. One of the things I learned to do as I became more experienced, that when my patients were admitted to the hospital and the admitting physician translated the outpatient medication list, I would tell them to be very cautious about the doses and the amounts that they were going to give to patients, because many a time we would crash patients' sugars or crash their blood pressure because I kept escalating the dose of the blood pressure medication because they weren't supposedly responding, but the reality was they never were taking it in the first place. So it's interesting to see how people with total integrity, honest, upstanding citizens of the world would not acknowledge or not feel comfortable to admit that they were not taking their medications. And the truth was completely kind of exposed when they would crash when you gave them their home doses. Actually, the nurse handed to them and watched them take the medications.
I think it's a really important point, because I think traditionally a lot of patients want to have a positive relationship with their doctor. So it's not unusual for them to give the answer that they think the doctor wants to hear, rather than just saying, I hate to admit it, but I really haven't been taking that medicine. They know it's important to the doctor somehow that they take it, so they say that they're taking it. And it is a maturing issue as a practitioner to learn how to filter through those issues. I'd give also, just for myself as a pediatrician, a simple example that's very relevant today. Is I had a couple of patients in my practice who refused the initial vaccinations for their baby, and the baby ended up getting whooping cough, pertussis, which the whole reason for vaccinating newborns and 2-month-olds for pertussis is because it's such a dangerous illness at that age. And they ended up with pertussis in the intensive care unit in the hospital. Fortunately, the couple that I had in my practice over time both survived it, but it's a really dangerous illness. And it's just a simple example of, people make a choice, and sometimes it has, pretty substantial implications.
Mhm. So let's kind of segue into that because I think it's a really important matter and very much something that's happening in the current context. At the patient level, there's obviously a lot of factors at play. There's much discussion and debate in the United States right now about physicians making recommendations to their patients to get vaccinated against COVID. Yet there's a very significant cohort of individuals, some 80 million adults in the United States, who aren't heeding this advice for one reason or another. So what else is at play here from your perspective? I'd be interested to hear. Marty?
I'd start with, you mentioned at the beginning the cost of non-adherence to the system. If you look at this non-adherence to medication specifically, pharmaceutical companies are obviously very interested in this issue, because if people aren't filling their prescriptions, then they're not meeting their sales objectives for those medications. So the pharmaceutical industry has invested a lot in trying to understand what drives patient adherence, particularly for medications. And consistently, the surveys that they've done have shown three foundational issues that get in the way. The first one is a lack of full understanding of why they need to do it. The second one is fear of side effects. And the third one is financial or access issues. It's either too expensive or too difficult to get the prescriptions filled. And I think those underlying issues apply to the situation we're in today and have just been further complicated by the politicization of this issue and the confusing messages that have come out publicly that make it very difficult for people to navigate these two big issues of why should I do it and what are the possible side effects of it.
Mm-hmm.
Interestingly, I think that the way we referred earlier to the emotional context, the relationship in which the recommendation is being provided as a key driver of adherence or lack thereof. This recommendation was made as a public health recommendation, and by definition, in the absence of an individual personal relationship. And I had this interesting conversation just yesterday with a group of folks, and one of them commented that in the context of the COVID pandemic, we have seen our primary care physicians less, and that many of us haven't even had an opportunity to hear their opinions about the vaccination. So there has been an absence of a trusting relationship, and add to that many of the folks who are resistant or hesitant to take the vaccine have had prior experiences with the healthcare system, individual providers, the broader system that have been traumatic or not positive, and that has created kind of a foundation of lack of trust. So that context that's again a deterrent. Thankfully, there have not been a lot of barriers for access that Marty referred to, but there still are some in some rural areas. Initially, when the vaccine was rolled out, there was a scarcity, there was difficulty making appointments, and people got, I think some people struggled with getting in to get the vaccines at that time.
Mm-hmm. So, on this topic of encouraging individuals to get vaccinated, what do you think can be done? Are there lessons from the research around medication and treatment adherence that point us in the right direction or might be applicable here?
Well, I think Betty touched on a couple of the important issues already. That one, talk to a professional who you trust. So I think there's some obligation or responsibility among primary care practices to be reaching out to their patients. Hopefully they have the infrastructure to identify who has and hasn't been vaccinated, and to really proactively be having those conversations to identify what are their barriers. Is it that they don't understand why? Is it that they are worried about side effects? What are they worried about? What's their experience been? it goes back to the trust thing. You meet them where they are and you try to help them get to the best decision for themselves. And meeting them where they are is also about making sure it's convenient, I think. I still think there's a subset of people where, taking off time from work, getting the transportation issues, getting to where the vaccines are being delivered are also still barriers.
Yeah, I agree with Marty. And just breaking news from this morning in Israel, they just recommended a third shot to the population over 60. So as of Sunday, all individuals over the age of 60 in Israel are going to get a third shot. So here we are with the kind of logistic challenge of getting 330 million citizens vaccinated twice or once for Johnson & Johnson. We're probably sooner rather than later going to be facing another challenge there. But I think one of the important aspects of the public and individual conversation about vaccines is to be non-judgmental about people's reservations and concerns. You have to be willing to listen with no judgment to what has led people to make that decision, and at the same time be transparent about the things we don't know and the risks that we need to acknowledge. There are unknowns about this vaccine. It is a new technology. We do not have patients who've had a messenger RNA vaccine 5 years ago. We are learning as we go. The recommendations have shifted and changed. It's very unnerving to people to say, which is it? And I think my experience has been that if you are honest with patients about your concerns or the reasons why you had worries about it but overcame them and what the rationale for that was, patients appreciate that and behavior is changed.
It's a little anecdotal, but I consistently have seen on the news interviews with folks recovering from COVID in the ICU. They've just been, come off intubation and they're recovering. And they have a conversation with their doctor around, well, should I get vaccinated now? And one of the things that often comes up is, patients really didn't have an understanding of how severe the illness was going to be. And many physicians that have been working in hospitals and serving COVID patients are, expressing that it's so important for individuals to really understand the potential side effects of the inoculation are nowhere near the potential side effects of having the disease itself, let alone the long-term implications of COVID and these long haulers, which we're just starting to understand. So there's really, clearly a lot at play here in making these decisions for folks, and hope that we brought some different topics to the fore for folks to consider. Thank you, Dr. Marty Lustig and Betty Rabinowitz, for joining me today, and our listeners also for tuning in. If you'd like to listen to more episodes of the NextGen Advisors podcast, hit the subscribe button. This is Graham Brown with NextGen Healthcare. Thanks for joining us and have a great day.